Hello, everyone. My name is Dr. Jack McNulty, officially John P. McNulty, and today I would like to discuss some of the changes that have occurred in the practice of medicine, and we're going to call it palliative care then and now, beginning with my beginning of the practice of internal medicine in New Orleans in 1957 and bringing it up to 2015. I'm going to quote Albert Einstein. He has said, "Only a life lived for others is a life worthwhile." And it's become appallingly obvious that our technology has exceeded our humanity. He said this in 1955. So, palliative care, begun in the late 1990s, was conceived as a way to correct the flaws and gaps in care of the suffering ill, especially those with life-threatening or terminal illnesses. A major flaw: doctors did not communicate well with patients and family. Talking and listening with patients was not emphasized. The emphasis was on disease, their diagnosis, and cure. Science overruled the art of caring about people. Did we have palliative care in the 50s, 60s, and 70s? Yes, I think we did, but we didn't call it palliative care. It was what an internist did if he practiced the standard of care. As a personal physician, he or she communicated well with patients, was easily available, building trust, educating patients about their illnesses, and when the time came, helping to ease their suffering at the end of life. The system was in balance. Now, when did it change? What caused end-of-life care to change? Malcolm Gladwell might call this a tipping point, because this was perhaps the most dramatic situation when cardiopulmonary resuscitation, or CPR, was successful. I remember the first time I was successful in resuscitating an adult male with an acute heart attack in 1969. I was euphoric. I felt so powerful, and physicians in general were excited. The public was also excited, and they began to think that death was an option. You docs can keep us from dying. And so after a while, hospitals were forced to protect themselves from lawsuits by families demanding inappropriate or futile CPR. It took away the ability of physicians to make a judgment when it was appropriate or not to attempt CPR. This was a very difficult situation when attempted CPR was done on elderly people, frail, at the point of death. Death would be a relief. As a result, this has been called the medicalization of death. Instead of a natural, normal death, appropriate for that patient's age and condition, we were obliged to do this futile CPR. Now, around that same time, in the 60s and 70s, there were a number of technological advances which led to specialization and fragmentation of patient care. Why was that? A physician who's doing general internal medicine has a lot on his plate because you needed to be capable on a variety of internal medicine conditions. And so it was easy for someone to become a gastroenterologist or a nephrologist or a cardiologist. I didn't want to do that, incidentally. I love taking care of people. And it seemed that it was my choice to continue to be in internal medicine, general internal medicine. This fragmentation of patient care meant that a patient would have a number of physicians, one for each organ system. And this diminished the relationship between the doctor and the patient. They were split up by having a specialist for each of the patient's conditions. End-of-life care was not well attended, and in 1982, the Medicare Hospice Benefit Act was enacted. It allowed the government to certify profit and nonprofit hospices so that a patient who was expected to die within 6 months or less was eligible for this program. The fact that physicians no longer had to deal with end-of-life care for those patients who chose hospice meant that they didn't have to be as interested. They didn't have to use the same care and concern about end-of-life patients. And this caused a great deal of discomfort among those of us who were empathic and felt like they deserved better care. At the same time, in the 70s, evidence-based studies became the standard of care in medical science, and there was less focus on the humanistic needs of individual patients and families. I remember teaching a group of freshmen, first-year medical students, and they had empathy, and they were very concerned about all of the palliative care and empathic ideas. By the time they got into their third year, which was the clinical work, they were more obliged to talk about the condition, the disease, and the cure. And it diminished the relationship between those students and patients. They were cases, not people. In the 1980s, in an attempt to reduce costs and manage patients better, managed care organizations teamed up with the insurance industry, inserted a third-party payer system which controlled doctors' orders and abilities to do what they felt they should do, and it also impaired doctor-patient relationships because you no longer had the patients that you had cared for years. And then finally, population medicine, the business of medicine, has developed over the last 20 years and has reduced the time and ability for doctors to have better patient contact. So all of these changes resulted in medical education was about disease and cure, not paying attention that the care of patients extends from birth to death. And the humanistic art of medicine was neglected, and particularly communication skills were not taught. So when did care get better? Palliative care as a specialty began in the mid-1990s by academic and hospice physicians to improve the care of suffering patients at the end of life in response to public complaints. Important to realize that the public was not satisfied with the care their loved ones were receiving. So a landmark evidence-based study called the SUPPORT study, a 5-year study from 1990 to 1995, tried to find out if a trained registered nurse and social worker team in that hospital was effective in increasing the rate of referrals to hospice. The result? it didn't work. And it was obvious that doctors must get involved again in end-of-life care. So that led to the development of the American Academy of Hospice and Palliative Medicine. Let me define palliative care as we know it now. Palliative care is specialized medical care for patients with serious illnesses, not just end-of-life illnesses. This type of care is focused on providing patients with relief from the symptoms, pain, and stress of a serious illness, whatever the diagnosis. The goal of palliative care, relief of suffering, improve the quality of life. In explaining palliative care to patients and physicians and other healthcare professionals, we want to describe it as a new layer of support to the care of patients, which is provided by an interdisciplinary palliative team that is a palliative physician, a nurse, a social worker, a chaplain, and additional people as needed, which is developed in response to these 4 glaring inadequacies in the care of seriously ill patients. And it attempts to restore the balance between the science and the art of medicine, which has been slowly lost over the past several decades, by focusing on the needs and goals of suffering patients and their families. What are the 4 gaps in patient and family care in 2000, 15 years ago? Number 1, communication. Talk to us, listen to us, explain to us. Number 2, patient autonomy. Respect us, understand our wishes, allow us to participate in decisions about our care. 3, impersonal care. Don't abandon us. Treat us as people, not cases. Remember that with patient autonomy, we can accept or reject a treatment. We have that ability. And this business of saying we can't do anything more for you amounts to abandonment. And we can do something. We can do lots of things to help people. We may not be able to cure them. And then finally, help relieve our suffering and our pain. Those 4. And when we talk to patients about this, they tell us they have difficulty talking with their doctor. They have shorter visits, and their care is fragmented. So our mission as palliative care practitioners is to communicate that role of palliative care to patients and families, healthcare professionals, and the public, so that they know that we are helping them cope with serious illnesses. And how do we do that? We do that by education. We educate and we educate. There was a study in 2011 by the Center to Advance Palliative Care to find out how much people knew about palliative care. 70% of patients and the public had no knowledge at all. 14% had some knowledge, 3% were knowledgeable, and 5% very knowledgeable, and 8% didn't know. The Center to Advance Palliative Care has been a leader in trying to spread the education and the development of palliative care programs around the country. So their study indicated that patients in the family and the community don't know that palliative care service exists. The term palliative care had little to no meaning to consumers, and the medical community has had difficulty changing their mindset about end-of-life care. And I've been talking about palliative care for the past 15 years, and it is true. When I began, palliative care had no meaning. And in traveling around my community in Louisiana and Mississippi, over time there has been gradual acceptance. And probably around 2010, there has been a very large increase in knowledge about palliative care and development of palliative care in the medical community. The Center to Advance Palliative Care in 2011 surveyed 800 patients between 18 and 65. They wanted to find out what older and younger patients knew about palliative care and find out how to discuss palliative care with consumer audiences. So they needed to know what they knew and how did they improve knowledge among consumers. In 2011, as opposed to the serious gaps in 2000, 58% believed that doctors might not provide all of the treatment options or choices available. That's a communication issue and maybe a trust issue. 55% believe doctors might not talk and share information with each other. That's again a trust issue. 54% believe that doctors might not choose the best treatment option for a seriously ill patient's medical conditions. That's another trust issue. Patients aren't trusting doctors. 51% say leaving the doctor's office or hospital that they were unsure about what to do when they got home. That's a communication issue. 51% of patients and families believe they do not have enough control over their treatment options. That's an autonomy issue. And 50% say doctors don't spend enough time talking with and listening to patients and families. Again, a communication issue. When they asked younger and older individuals whether they thought that serious illness was the same as terminal illness, they didn't think so. And they asked whether they thought advanced illness was the same as terminal illness, and they didn't think so. Which means that in 2008, we had to expand the reach of palliative care. It was getting to the situation where doctors were thinking that palliative care and hospice were basically the same. And we don't think that at all. And as a result, now, seriously ill patients who are suffering and have impaired quality of life are eligible for palliative care consultation. And these survey that the Center to Advance Palliative Care reported that 95% of the consumers agreed that patients and families should be educated about palliative care. 94% agreed that it is appropriate at any age and any stage in serious illness, and 80% agreed that palliative care should be covered by health insurance and Medicare. The Institute of Medicine in 2013 included palliative care into cancer care. The bottom line was palliative care is critical to high quality and should be delivered across the cancer care continuum, which means that at the time that a diagnosis of cancer is made, a palliative care consultation should be made. And what that means, it doesn't mean that the palliative care members are going to have a lot to do early, but it means that they will be able to develop a relationship, and when should things go bad and they would be needed, they would be in place and ready to deliver. And should the situation develop that hospice care is necessary, the transition is much easier when palliative care is on the team. So, how many hospitals are providing palliative care at the present? 67% of hospitals having over 50 beds have a palliative care program. We really don't know how effective that palliative care program is or how well it's staffed, but at least we've got 2/3 that are having some kind of palliative care program. 90% of hospitals having over 300 beds, big hospitals, have a palliative care program, and 56% of hospitals with less than 300 beds have a palliative program. In 2015, Louisiana is a C. Mississippi is a D. Mississippi has small hospitals without the ability to staff a palliative care program, and Louisiana was a D 10, 12 years ago. Mississippi was an F. So things are getting better, and we've been fortunate to be able to visit rural Louisiana and Mississippi as part of our palliative care program to educate the staffs of hospitals and hospices who don't have the resources to send their staff to the big conventions. So in 2015, things are looking up. The medical and nursing schools are now teaching palliative care. Some rotate students in palliative care and hospice inpatient and outpatient units. Palliative fellowships, 1 or 2 year fellowships, are available throughout the USA. So in summary, there are many national organizations offering programs and courses in palliative care. There are many resources now available, and the future is bright.